Report number 1. The gallbladder is well visualized and it is normal in size, shape, position, and density. There is no evidence of biliary calculi. Following, the gallbladder decreased in size. However, the emptying function seems to be delayed. Report number 2. Treatment consists of surgical removal of all visible tumor. Prognosis is good if this is accomplished. It cannot be removed completely. A vigorous attempt should be made at subtotal removal, almost regardless of the extent of metastatic disease. The site of obstruction should be bypassed. Report number 3. Radiographic examination of the right shoulder reveals no evidence of fracture, dislocation, or periarticular calcification. Report number 4. Physical signs most often observed are those of intestinal obstruction or an abdominal mass. Röntgenologic examination of the small intestine frequently gives negative or misleading results. The most characteristic clinical pattern is that of a malignant neoplasm producing partial obstruction of the small intestine, the obstructive symptoms being of unusually long duration. Report number 5. There is no evidence of pulmonary pathology. The heart is normal in size, shape, and position. The aorta is normal in width and outline. The diaphragm and costophrenic sinuses are normal. Incidentally, noted are a few calcified lymph nodes at the left hilum. Report number 6. Close suction of clean surgical wounds and closed circulation and suction of infected, potentially infected, and marginally clean wounds aid greatly in wound healing. Use of the methods has become more widespread with the development of a small, multi-perforated, siliconized, non-collapsible, and non-irritating polyethylene tube to replace the clumsier rubber catheter. Report number 7. There is a round soft tissue shadow at the right hilum, most likely due to an enlarged lymph node. The left mid-cardiac segment is prominent due to widening of the left pulmonary artery. The aorta is normal in width and outline. The diaphragm and costophrenic sinuses are normal.
Report number 8. Examination of the nasal sinuses failed to reveal any evidence of pathological changes. The bony portion of the nasal septum shows deviation to the right. The turbinates are larger than the average. Report number 9. In infants and children, an enlarged thymus gland may contribute to a deformed cardiothymic image on röntgenograms and mask the true appearance of the heart and great vessels. In such instances, administration of adrenal glucocorticoid derivatives causes the thymus gland to shrink temporarily and allows unobscured films of the chest to be made. Report number 10. The left leg shows evidence of bone destruction in the cortex at the junction between the middle third of the tibia and in the adjacent area of the medulla. In the same area, there is calcifying periostitis. A bone tumor should be considered first. A general bone survey and determination of the calcium, phosphorus, and alkaline phosphatase may furnish additional information. A biopsy would also be advisable. Report number 11. Patients with sudden cardiac arrest may be resuscitated by external cardiac massage with artificial ventilation of the lungs. The procedure, which compresses the heart between the sternum and thoracic vertebral column, is safe and simple. Open thoracotomy and direct heart massage restore circulation, but this method requires a surgeon and equipment, and often, therefore, is dangerously delayed. Report number 12. Examination of the lower part of the colon by a double contrast method reveals as follows. The changes in the distal third of the sigmoid are the same as at the previous examination and suggest polypoid thickening in this area. It is open to question whether this finding represents a variation of the normal or a localized inflammatory process or a new growth. A sigmoidoscopic examination may furnish additional information. Report number 13. Although infusions of homologous bone marrow do not improve the overall survival rate with hypoplastic anemia, some patients have immediate beneficial hematologic effects, and a few are apparently cured. Results are best when donor marrow is obtained from a close relative of the patient. Splenectomy may enhance the effect of marrow infusion. Corticosteroids probably should not be given to allay the homograft reaction. Report number 14. The left elbow shows evidence of a vertical type of fracture between the radial and middle third of the head of the radius. The smaller fragment is slightly depressed. There is also calcification below and anteriorly from the medial epicondyle of the humerus. These latter changes suggest calcification in a hematoma. The right elbow is normal. Report number 15. Diastolic blood pressure can be estimated by palpating the brachial artery during deflation of a sphygmomanometer cuff. As cuff pressure approaches diastolic pressure, a thin, abrupt, almost snapping single vibration is superimposed on the brachial pulse. This sensation disappears suddenly when pressure within the cuff falls below the diastolic level. Report number 16. There is a small exostosis on the external epicondyle of the humerus. It is open to question whether it represents a true exostosis or a calcified periostitis or an old of fracture. A comparative X-ray examination of the other elbow was not advisable because of the marked anatomical changes on that site. Report number 17. One-sided temporal lobe lesions occasionally give rise to apparently independent bilateral temporal lobe discharges. Glial hematomas, angiomas, and other neoplasms, though too small to distort ventricular contours significantly on pneumoencephalograms, may nonetheless result in two-sided spike discharging foci. Epileptic seizures resulting from the lesions may be completely or greatly improved by unilateral temporal lobectomy. Report number 18. In the chest, there are productive fibrotic changes in both upper lung fields and a few in the left mid-lung field. In the same area, there are also round foci of decreased density. These latter findings represent bronchiectatic dilatations. Additionally noted is pleural thickening in the left apical area. The changes described are most likely tuberculous in origin. Laboratory findings and clinical observation would be advisable to confirm this diagnosis and determine activity. Report number 19. The pelvis, with special reference to the left hip, shows no evidence of fracture or dislocation. Incomplete bony union of the posterior arch of the first segment of the sacrum is noted. Report number 20. Because symptoms mimic those of acute appendicitis, diverticulitis of the cecum and ascending colon is difficult to diagnose preoperatively. However, right-sided diverticulitis should be suspected when a patient who has had an appendectomy has persistent abdominal pain and a palpable mass in the lower right quadrant, slight fever, and, perhaps, nausea and vomiting. Report number 21. The lumbar spine, lumbosacral, and sacroiliac region show evidence of scoliosis at the level of the upper lumbar spine to the patient's right. There is also evidence of spondylarthrosis with spurs on the vertebral bodies. The intervertebral spaces, the intervertebral foramina, and the interpedicular spaces are normal in appearance. Report number 22. Radiologic examination with a barium enema, probably the only significant diagnostic aid, may disclose the diverticulum. Operative diagnosis is more accurate. Nonetheless, besides diverticulitis, an inflammatory cecal mass may suggest cancer, tuberculosis, actinomycosis, amoebic cechitis, or carcinoid, and regional ileitis. A hidden diverticulum may simulate carcinoma when inflamed. Report number 23. Excessive blood levels of calcium frequently accompany malignant disease, especially breast cancer. Hypercalcemia appears insidiously, often without symptoms and without radiologic signs of bone involvement. Initial symptoms usually are referable to the gastrointestinal tract and include nausea, vomiting, anorexia, and constipation. Drowsiness, lethargy, stupor, or other manifestations of disturbance within the central nervous system may not appear until the serum calcium level has risen further. Blurring of vision may be noted. Diplopia, dysphagia, and similar symptoms may be due to profound muscular weakness and not to focal disease within the central nervous system. Thirst, nocturia, polyuria, and dryness of the mouth reflect the underlying disturbances in water metabolism. Report number 24. The upper gastrointestinal tract shows evidence of a partial resection of the upper part of the esophagus with displacement of the stomach high in the chest on the left side. The esophagus is displaced anteriorly and to the left side, just below the level of the clavicles. At the same site, there is narrowing of the lumen and an irregular round filling defect which is highly suggestive of enlarged lymph nodes. Adhesions should also be taken into consideration. The lumen of the duodenum is markedly widened due to a partial obstruction around the duodeno-jejunal junction. Partial resection of the posterior part of the sixth rib on the left side is noted. Report number 25. Because excess serum uric acid is common with both conditions, gout and hyperparathyroidism may be related. Therefore, serum uric acid levels should be determined in patients thought to have primary hyperparathyroidism, and hyperparathyroidism should be considered in patients with gout, especially those with recurrent ureteral lithiasis. Parathyroid function and uric acid metabolism are not physiologically correlated, since hyperuricemia persists after surgical correction of hyperparathyroidism. Report number 26. Examination of the dorsal spine shows evidence of arthritis on the vertebral bodies. There is no evidence of osteoporosis or any destructive pathology. Report number 27. The left hand shows that there is no fracture, dislocation, or a foreign body. There is soft tissue swelling adjacent to the index finger.